So we're going to talk briefly about vasopressin. Got one or two slides on vasopressin. Why I'm talking about it again, it's new and upcoming. Vasopressin is also called ADH or antidiuretic hormone. It's the same thing. What it does, it stimulates the V1 receptors on the vascular smooth muscles. So it causes a vasoconstriction. It's a drug that we use as an alternative to epinephrine. So it's the same kind of idea with epinephrine, that you want to give the blood vessels a squeeze to cause potentially better blood pressures than if epinephrine doesn't work, or you kind of want to be on the cutting edge and use a new drug. If you have access to it, then vasopressin can be substituted for epinephrine. The studies, early studies, none in veterinary, or very limited, I should say, in veterinary medicine, mostly in human medicine, shows that vasopressin may improve coronary perfusion pressure, myocardial blood flow, and cerebral blood flow, again, in relation to epinephrine. So vasopressin may be a little bit of a better choice. There are no real studies that show that there's a true advantage over epinephrine. So right now, the 2010 consensus statements, again, just recently released, they still say epinephrine is the first-line drug. So right now, still no evidence to say that vasopressin is the drug to go to. I think it's just an up-and-coming riser that we have to keep our eye on. The dose difficult, it doesn't follow the 10% rule, but it's very similar. So the dose reported is to do 0.2 or 0.8 units per kilo given IV, only that I know of, to be given IV. The standard bottle of vasopressin is 20 units per kilo. So for a 10-kilo dog, instead of giving 1 ml of this emergency drug, you give 0.1 ml, and that will be the low dose of this vasopressin. So it doesn't follow the 10% rule, but it's like 1/100th of the dose. So it's still something, hopefully, that you can wrap around your brain. This chart came out of a recent DACVECC, or Journal of Veterinary Emergency Critical Care article, 2009, and it just shows you where you can apply vasopressin. And so I'm pretty much just going to follow the green side down here, where if you have no pulse and you don't hear a heartbeat, then AVP or vasopressin, after you start compressions while you're waiting for someone to drop the drugs, then certainly that is a drug here that you can see here that they advise or is accepted to give. But the or here is that you can give epinephrine. So again, it's not something that you guys will have to worry too much about, because usually the doctors will dictate what drugs to be giving. But that's just a chart that is available if you guys ever wanted to know a little bit about where and how vasopressin is used a little bit more. Okay, so last slide I need you guys to remember, if you can, is I think it's great that we talked about how to do CPR and how to stabilize emergency patients, but I think what's more intuitive and what's better is, instead of having to do CPR, know which patients are liable to arrest and to prevent CPR from ever happening or ever being needed. And so for me, there were very few things listed on here that you can see that is very easily identifiable or measurable in your patients, or could be measurable in your patients, that can put your, I guess, radar on high alert. And if your patient has one of these conditions, or 2 or 3 of these conditions, I guess for me, try to do things about that to reverse them, or be on high alert and not be surprised that this patient may arrest. Because I think the disorganization of cardiac arrest and resuscitation usually comes from the fact that everyone's like, wow, I didn't know that was coming, or I didn't know that I wasn't prepared for it. And so for me, if I have a patient in the ICU that has, like, we'll say 4 of these pre-arresting conditions, literally take all your emergency supplies, put it right next to that kennel. Because at some point in this shift, I'm going to expect this animal to arrest. And if it doesn't, that's great. We've done a great job trying to, again, reverse some of these conditions. So the pre-arresting conditions, again, like I said, easily identifiable on most of your patients is hypoxemia, low O2. So you can do that with a pulse oximeter, right? You can grab it and see if they look pale or cyanotic or just not pink, then see what their SpO2 is. Hypercapnia or high CO2, that's a little bit more difficult to measure. You either need a capnographer or a blood gas, so I'm going to have to leave that to whatever equipment you guys have. Bradycardia, easy, right? Listen to your patients and see what their heart rate is. Bradycardia more so than tachycardia, because we have a lot of patients who are tachycardic, whether they're due to stress, pain, anxiety. So tachycardia is a commonly identified phenomenon in veterinary practice, but bradycardia is very uncommon, right? You usually don't have that unless it's drug-induced or unless they're about to die because their heart is just about to quit working. Cardiac arrhythmias we've gone over. Anemia, so look at their gums or check a PCV, like 2 cents to do a PCV, right? So you can check a PCV anytime. Hypothermia, take a rectal temperature, see if they're cold. Again, more than hyperthermia, absolutely hyperthermic patients can die, heat stroke, DIC, stuff like that. But usually our patients are hyperthermic for a reason, like they've got a fever or they've got intense inflammation. If they're hypothermic, then that's a little bit of a concern. And for me, the crude way I remember that is when a body is about to die, it's not going to want to send blood to the rectum. It's going to want to save blood for the heart and the brain. So when you're not perfusing your ass, you're going to be hypothermic. And so if you can't register or you have a low rectal temperature, then there is likely a perfusion problem in your patient. And so we have a lot of heart failure animals come in hypothermic, and that's because they can't send blood to their butt. They're saving it for the heart and the brain. Hypotension, so low blood pressure, either do a Doppler or whatever other means you have. And then electrolyte imbalances, again, depending on what lab abnormalities you guys have available for you. Electrolyte abnormalities, especially potassium, can be devastating and easily correctable. And so I'll leave it at that with questions. I do see a few of my colleagues in here, meaning our hardworking Canada West veterinary technicians. You've seen some of them talk. I do want to take this time to actually thank them and let them know that they're truly the unsung hero of our profession, as all of you are, but for me to be able to thank them for the hard work that they do and to tell them to keep it up. Thank you.